Might just have to sit for a bit.
Good evening, everyone. Welcome to the webinar. My name is Claire. I'm editor of Medical Chronicle. I'm joined here by Dr. K. Mohammed and Dr. Bronwyn Bosch, who will present on understanding HIV drug resistance through case studies. The webinar is sponsored by Thermo Scientific. A bit of background information. Dr. Mohammed has been a medical doctor for over 30 years and has 12 years of experience in the management of HIV/AIDS and related diseases. Her passion extends beyond patient care and shows in her devotion to the training of doctors, nurses, psychologists, social workers, peer educators, and mentors in HIV/TB care. As the lead consult at Garden City Clinic, she takes professional pride in ensuring that clinical protocols are aligned so that all patients in her network receive the best care with minimal complications and rates of opportunistic infections. While Dr. Bosch is a research clinician at Izintia, part of the University of Witwatersrand in Johannesburg. Her areas of interest include HIV drug resistance and provision of long-acting antiretroviral options in the South African context. She is involved in several HIV treatment optimization trials conducted through Izintia and is a member of the South African Third Line ARV Treatment Committee. Here is some guidance for the webinar. There's a box at the top of your screen that says Reconnect. Please click this if you have any issues or if you have a bad connection. It will bring you right back into the webinar. There will be a recording available of the webinar to watch. CPD points are based on viewing time, so please do watch the full presentation. As per HPCSA guidelines, we no longer issue CPD certificates directly, but pass on this data to the HPCSA, where you can view your points on their portal. If anyone would like an attendance certificate for pharmacists, please email me or John Woodford if you have his email address. Please type in any questions that you have in the Q&A only box provided. I need to point out that we will not be addressing any off-label use of products, and as per CPD requirements, no brand names are to be mentioned, active ingredients only, please. Okay, so without any further ado, I will start the presentation for our doctors tonight and hand you over to them. There we go.
Good evening, everybody, and thank you for joining us for this evening session. So Dr. Mohammed and I are hopefully going to give you some practical guidance around clinical cases. We're going to go through quite a few case studies, but the thought is that we can hopefully get a pattern going so it becomes a little bit more accessible for you. All right, these are my disclosures. So just a background, what is HIV drug resistance? This was covered in the first webinar, but just a brief overview. Basically, HIV drug resistance is a result in the change in the HIV genetic structure. And with that, there's impedability of ART to prevent replication of that HIV virus. It can be either acquired or pre-treatment drug resistance. And the importance here is that it really compromises the efficacy of the ARV regimens that we have available. With that, if patients are not virologically suppressed, they're at a higher risk of HIV-associated morbidity and mortality. And it also informs the selection of our standard first and often second line ART regimens. So Dr. K, over to you.
I'm going to start with the first patient, who's a 30-year-old female who presented in June of 2017. She presented at Garden City Clinic with diarrhea, and in addition to that, she did admit to having poor adherence. So having looked at her blood results at the time, you can see the fact of the poor adherence coming through. Her viral load is extremely high, sitting at 345, 406. The CD4 is still a bit decent at 667, and the creat was 44. So this is what happened when we saw her initially, and then one needs to go into a previous drug history only to realize that she was initiated on ARVs in 2007. And at the time, she was put onto AZT, 3TC, and efavirenz. And then what happened is in 2009, she experienced virological failure, and she was, can you just give me one moment, please? One moment.
Sure.
Romana, the screen is blank. Mohammed. And then in 2009, she experienced virological failure and she was switched then to TDF-3TC and lopinavir with ritonavir. Subsequent to that, she then moved to the private sector where she, kept on switching between private and public, and then went back into public again. And in public, they again switched her to abacavir 3TC and lopinavir with ritonavir. So this is what happened in 2009. So when we saw her, she was on the abacavir 3TC and lopinavir. And in view of the diarrhea, what we decided to do immediately is to take her off the lopinavir, ritonavir, and switch that to atazanavir, so hopefully the diarrhea would settle. Within a few days of being in hospital, she presented with lymph nodes, and a biopsy of the lymph nodes was done immediately, and a diagnosis of TB was made. And when the diagnosis of TB was made, her ARVs needed to be switched. She needed to come off the atazanavir nova, and she needed to go on to, and what we decided on is we were going to give her AZT3TC with dolutegravir BD to cover for the TB as well, and TB treatment was then initiated. But a few days after that, of having initiated the dolutegravir BD, she complained of insomnia. And what we did is that we tried to play it down. We counseled her and said, you know what, just try and push through with your meds. And hopefully, by the time your TB treatment is finished, all will be good and well. And then we saw her much later on, and this was now in February of 2018. And at that time, she did admit to defaulting the night dose of dolutegravir, because she figured out that if she skipped the night dose of dolutegravir, she could sleep. So, if you think patients are not smart, here's a very smart lady who decided that she'll drop the night dose of dolutegravir, and that would allow her to sleep. But also remember, at the time, she was on TB meds, but thank God the TB meds had gone to 7 months already. And this is when we decided that we needed to do a resistance test, because we needed to know where we were with her ARVs in view of the fact that she was skipping the night dose of the dolutegravir. Dr. Bosch, I would hand over to you.
All right, so this is her resistance test that you can see here on the right-hand side. And in this patient, she's had quite an extensive ART history. I've put up some of the drugs here at the top that she's been exposed to, including an integrase strand inhibitor, which we know is really strong. But in instances like concurrent use with things like rifampicin, you do need to double the dose. And if that is being skipped, there is a high chance of integrase strand inhibitor resistance occurring. So this is a very early case of dolutegravir resistance that was shown. And if you have a look at this resistance profile, we can see here that the NSTs have been compromised. In NRTIs, we assume there is going to be resistance, and we really don't look at them into the second and third lines because we know that their genetic barrier to resistance is not as strong as some of the other agents we have available. So remember that for the cases coming up as well. So what we're going to focus on are the PIs and the NRTI options that we have up here. You can see that the patient is really susceptible to all of the drugs, which is fantastic for us. And with the NRTIs, we can see that the TDF is susceptible, TDF and AZT. TDF is definitely preferred over that. And we have some resistance to some of the other NRTIs. So what the patient was then switched to is atazanavir, ritonavir, which was boosted, and then TDF FTC. What you have to remember here is that when you are using agents that are compromised by rifampicin, you have to switch the patient to rifabutin if available. Because the patient had been on TB treatment for 7 months, patient was switched across to a continuation regimen, so with rifabutin and IMH. And what we saw, June 2018, the patient then completed 9 months of TB treatment, so 2 months later, the viral load was significantly improved compared to what it was previously, and the CD4 looking really good. So at that point, same regimen was continued, and the patient subsequently suppressed a year later with really good reconstitution of that immune system and remained virologically suppressed thereafter. Okay, Dr. K, back to you.
Thank you very much, Dr. Bosch. Case number 2 is of a 47-year-old female who initially presented with the history of having defaulted treatment. So she comes into the room and she says, "Doctor, I'm really very sorry. I haven't been taking my treatment." And then we do the bloods on her. Her viral load is sitting over 500,000. Her CD4 is sitting at 12. Her creat is 48. And remember, with patients like these whose CD4s are really very low, we need to ensure they don't have TB. So a urine lam was done and it was negative, and a cryptococcal antigen was done and that was positive. So when we saw her, at the time, we asked her to come in for admission to do an LP to exclude cryptococcal meningitis, and the patient was absolutely disinterested. There was a lot going on in her life, and she said no. So we had gone into her previous history. It appears that she'd been initiated on ARVs in the public sector a long time ago, and also during some point in her life, she was treated for TBM and TB abdomen as well. She wasn't very clear as to what treatment she was on in all of that time. So what we decided is that in view of her bloods, we're going to start her on TDF, FTC, and put her onto a PI in view of the very low CD4 cell count as well, and started her on fluconazole and a multivite as well. So we saw her a few months later, and like I say, someone like this, you a little bit scared of, and you bring them in a little tighter as well. And when we saw her a few months later, she still had multiple social issues. We counseled her again. The bloods looked like a disaster again, with the viral load sitting at 250,000. The CD4 was just not moving at all, and the creat. And so we re-adhered her subsequently to say, you've got to take your meds if you want to do that turnaround. Got in touch with her work colleagues and got them to encourage her to try and do the best she can. And then we saw her a few months later, and this was in December of 2022. She still continued to have lots of social issues. But by December 2022, she was very adamant that she was taking her ARVs. And since she was adamant she was taking her ARVs, when we looked at her blood results, the CD4 was still low and the viral load was still very, very high, despite the fact that she is saying, "Doctor, I'm taking my meds." So we decided we had no choice. She was totally adamant she's taking her meds. The bloods were looking like a disaster, and we asked for a resistance test. Dr. Bosch, hand over to you.
All right. So with this patient, like Dr. K has highlighted, there are a lot of issues with adherence, whether or not she has been taking, admitting to taking. But at that point, if there is resistance, it's quite hard to come back from that with certain regimens. So a resistance test was done. Again, we'll focus on the PIs and the NRTIs here. So having a look, patient has been exposed to a boosted atazanova. Lopinavir, ritonavir, sitting around the same sort of resistance levels. We can see that darunavir has been compromised, but we know that darunavir out of the PIs is a really good drug. It is a really solid drug, and it is something that we in South Africa use as part of our third-line regimens. So darunavir is our option here, and we can dose at BD. And then we have to look at the NRTIs to see what we are going to pair this drug with. A lot of these drugs have been compromised. And in a patient where adherence is a concern, Often what we would like to do is take two NRTIs, put them together, those with the lowest Stanford score, the most susceptible to drugs, we could put them with darunavir. But what was decided here is we have dolutegravir as part of this regimen. We haven't had any exposure to any of the INSTIs, so it was decided that the patient would be switched to BD dosing of boosted darunavir, dolutegravir, and then continuing with the fluconazole and the multivitamins. You have to remember that this patient's viral load was through the roof. So if we are looking at improvement, we can see a massive improvement in the viral load with this patient. So she is currently doing much better. Her CD4 has improved dramatically, and her creatinine clearance, or her creatinine, has remained fairly stable. This patient was last seen in May of 2023, so is due for a follow-up, but we thought we would include her since she had shown such remarkable improvement. Okay, Dr. K.
Case number 3 is of a 59-year-old male who presented initially with a high viral load of 27,000 and a CD4 of 87. He says he was very adherent to his ARVs. But what happened is he comes in with a long history from 2002 of having been on ARVs in the public sector. So the impression we got is that he was on TDF, FTC, and efavirenz round about 2002. And that was subsequently switched in 2012 to TDF, FTC with lopinavir and ritonavir. So in view of the vast exposure to the ARVs and the long history of being on treatment, but more importantly, the fact that he was absolutely adamant that he was on treatment, we decided to do a resistance test. Dr. Bosch?
All right, so what you can see here, and if you have a look at the patient's history, patient has gone through a first and a second line regimen and is now failing on a second line regimen. So again, when we're having a look at the resistance test, the NNRTIs are not going to hold their own in the third line regimen. So we discount those bar etravirine, and we will come back to this. But if we're looking at the drug to basically hold that regimen, we're looking again to the PIs. And we come back to darunavir, ritonavir, which you can see here has really retained its susceptibility. With this, we would do BD dosing. If we have a look then at the NRTIs that we're going to put together, again, we want to look at the lowest Stanford score. You'll see some of the cases that come up a bit later. It gets a bit more tricky when patients have had exposure and side effects and concurrent issues. In this instance, we can play with what we have. So lowest here, TDF, which is fantastic, and we can pair it with FTC, which we know comes in a fixed dose combination. But in view, if you have a look, you see quite an extensive amount of resistance. Darunavir, yes, susceptible, but potential low-level resistance. So with this, to beef up the regimen, we added in dolutegravir. Again, no INSTI exposure, it's a nice add-on. And what can sometimes be done, and there's a lot of debate about when to include etravirine or not, is etravirine was added initially as a BD dose. Patient then was seen a year later, suppressed beautifully, CD4 was improving. And in light of this, it was decided that the ART would be refined. I think with all of these patients, we have to remember they've been on treatment for a very long time. A lot of them are fatigued. If any of us have to think about taking chronic medication, it's difficult. So where we can refine it, we will. And what was done here is that the DTG, TDF, FTC was combined into what we know as TLD. Darunavir was carried on at a BD dose, and the etravirine was dropped. And the patient remained virologically suppressed thereafter and has done really well since.
Case number 4 is of a 40-year-old male who presented to us with the history of having defaulted ARVs. At the time, his viral load was only 327 with the creat of 58. But according to him, he was initiated on ARVs in 2011, and he was on tenofovir, FTC, and efavirenz. So what we decided, because the viral load wasn't all that high, was to re-adhere him, and we reinitiated the same ARVs again because he defaulted. So we put him back onto his TDF, FTC, and efavirenz. And then he presented after that in 2019. Sometimes one also needs to realize that patients are mobile and they can switch doctors, switch provinces, change jobs. So you can kind of lose patients in between. So we hadn't seen him for quite a while. And when he presented in October of 2019, he was being looked after by another doctor, but the viral load was now 1,000 with the CD4 of 232 and a hemoglobin of 6.8. And he reported good adherence. So in view of that, what we decided is to do the earnest trial, follow the earnest trial, and we dropped the FTC and replaced the FTC with the PI. So he was put onto tenofovir, FTC, and atazanavir with Nova. And then he presents again after a couple of years in September of 2022. And now his viral load had really climbed through the roof. It was sitting at 48,000 and the CD4 was 371. So we re-adhered him again. And in January of 2023, he comes in again, but this time he swears absolute adherence. I'm taking my meds properly, doctor, but the bloods are saying another story. And now the viral load is 26,586. The CD4 is sitting at 212 and the creat is sitting at 57. And in view of the fact that he reported good adherence and he was on a PI, we had no choice but to do a resistance test for him.
Okay, and then what you can see here, so a resistance test was done. Again, we would expect there to be NNRTI resistance in lieu of the history. We can also see that the atazanavir boosted has been compromised. So you can see really high level resistance with that, which is likely why the regimen was not holding. And so looking at this in the PI class, again, thankfully, we have darunavir as our option. Darunavir in this instance, because the score is less than 0, we can consider once daily dosing, which again, if we're thinking about patients adhering to regimens and making their life easier, that really, if we can offer that, we do. Then looking at the NRTIs, trying to see what we could add alongside here, we can see quite high level resistance across all the NRTIs, which makes us think, let's add in another agent, which would be dolutegravir again in this case. Again, similarly to the previous case, TDF FTC we know comes in a fixed dose. If we want to add dolutegravir, lucky for us, there's TLD, which comes in a once daily dose. So patient was switched across to once daily doses of boosted darunavir as well as TLD. Patient was last seen in March of 2023, so is still due for follow-up and will hopefully be doing well when we next see him.
Patient number 5 was a 51-year-old male who presented in December of 2020 with a viral load of 5530, so the viral load was high, the CD4 of 282. And the problem here was that twofold. Firstly, he said he was adherent to his ARVs, but more importantly, he was also in a discordant relationship. And one needed to have acted on this rather quickly. So he said he'd been initiated on ARVs in the public sector, and he was not too sure about what his first line treatment was, but on his second line switch, they'd switched him to TDF, FTC, and lopinavir with ritonavir. So what we decided when we saw him, because a lot of patients we see who are on lopinavir and ritonavir default treatment because it's a BD dose, it has lots of side effects. And I always say to patients that it's the size of a suppository as well. So, to all the patients who do well on lopinavir, hats off to them. So the thing we needed to do with immediate effect was to take him off the lopinavir. So what I did is I switched his meds to TDF FTC and replaced the lopinavir ritonavir with atazanavir nova. And at the same time, in view of the fact that he's swearing adherence, he's in a discordant relationship, requested a resistance test.
All right, which brings us here to January 2021. So now this is very tricky. So you can see high level resistance across all of the classes. And I think, like Dr. K has highlighted, it's really important to remember that, we have algorithms for these things, but when the patient is sitting in front of you, you really need to tailor the treatment to that patient themselves. And unfortunately, the further down the line we get, we start to run out of options, but we also want to try and make it as easy as possible for patients. The pill burdens get a lot bigger. Thankfully, we have more fixed dose combinations now, but we have to be cognizant of that. So resistance test results were received. And again, as expected, we have NNRTI resistance. But then if we have a look at our PI and our NRTI. So our PI, the best in class is again darunavir, ritonavir, as we would expect. Patient has been exposed to lopinavir and atazanavir. So darunavir, again, is your option of choice. And in essence, this patient is now on a third-line regimen. So darunavir would be our option. Then we start to look at the NRTIs. Patient hasn't had any issues with creatinine function or renal function previously. So we can look at TDF. And again, FTC, 3TC seems to be our lowest Stanford score. So they make a good pairing there. And again, because the scores are so high, we have this overwhelming amount of resistance. Etravirine is not going to be any help to us here, sitting with a Stanford score of 30. So there is quite a bit of resistance there. Our go-to would be dolutegravir added on. So what the patient was then put onto is a BD dosing of boosted darunavir, as well as a once daily dosing of TLD. And the patient, just a few months later, did incredibly well. Viral load came down to suppressed, CD4 was doing okay, and creatinine remained stable. So the patient, after that, remained virologically suppressed thereafter and has done really well on this regimen.
Patient number 6 was a 59-year-old female who presented to us in February of 2015. At the time of presentation, her viral load was sitting at 4059, which is high-ish. Her CD4 was sitting at 390. A hepatitis screen was done on her, and the reason for the hepatitis screen that was done as well was because she had deranged LFTs. So the main one you need to home in on the LFTs, especially if they're on ARVs, is the ALT and AST. And we can see the ALT and the AST is considerably raised. And like I say, the Hep B screen is positive. So one needs to go into the previous drug history, which is absolutely crucial because it's important to know what meds they were on before to guide you along how you're going to think. And what we know from before is that she was on a lot of meds in the public sector. There's a history of AZT, DDI, TDF, FTC, and lopinavir, ritonavir, which means this patient was more like a second-line patient and, one of these that they were giving everything to. So in view of her being on ARVs for a long time and the impression of her being on second-line ARVs as well for a long time, we requested for a resistance test to be done.
All right, so
we just left her on TDF, 3TC, and lopinavir until we got the resistance test back.
Okay, so what we can see here, we have to remember this was also a very long time ago, and not, like Dr. K has highlighted, we're sitting with almost two different groups of patients. We're sitting with groups of patients who have come from the start of HIV, where the regimens were quite complex. Like Dr. K said, everything was thrown at them. which really complicates when they start to fail regimens, because a lot of the mutations you might not see at the time if patients are not taking their treatment and there's no drug pressure, but they might be archived, which is why the medical history is so important. But the other thing is that we have the second group of patients which, are generally doing pretty well because we have much stronger drug regimens. So you have to look at this in light of the time as well. So if we have a look at her resistance test, we can see that she is susceptible to all of her PIs, which is fantastic because it gives us options. With that, she is susceptible to all of the NRTIs. We have to keep just in the back of our mind, there might be some drug selection pressure when we don't have drugs and some archived resistance, but this is a good standing for us. So what the patient was then switched to, and as mentioned previously, lopinavir, ritonavir, really, it's done really well in clinical trials, but as soon as patients take it in the real world, I think a lot of us have had experience with patients being deterred by the GIT side effects as well as the dosing. So for ease of taking, patient was switched across then to a boosted atazanavir, ritonavir. And following that, the patient did really well. She suppressed beautifully. Creatinine was stable at this point. But what we saw a few months later is that the viral load had increased slightly. CD4 was stable, but the creatinine had increased as well. So this is where it becomes tricky. Thankfully, the NRTIs, if you remember from the previous slide, we didn't have any mutations. So we have some room to play around. So in this case, we assume that the TDF is likely the thing pushing that creatinine up and dropping the renal function. And for that, there's a nice easy solution. We can switch across to ABC3TC, as well as the boosted atazanavir. With this, important to remember, patient is Hep B positive. With Hep B positive patients, as soon as we drop that TDF, they are likely to flare up. So this is quite a tricky case because you have renal impairment, but you still need that TDF. So what was done here is that the patient had TDF taken twice weekly. And then a few years later, again, patient circumstances changed. They moved between healthcare providers, but the blood results on this occasion came back with a viral load of 28,000, so massively raised, and a CD4 of 811. So a few months later, patient was diagnosed with TB, just to make matters more complicated. Viral load was still very high, CD4 had dropped slightly, and the creatinine was nice and stable. And at this point, a second resistance test was done. So if you have a look at this table in the middle, you can see that the PI class is still, the susceptibility is still retained, which is fantastic news for us. And the NRTIs, we've seen the M184V crop up, which is great for TDF because it means it helps boost that, but that's not helpful here because of the renal impairment. So the decision at this point, patient hadn't had any prior NST exposure, so it was decided that the ART would be switched across to 3TC AZT as well as DTG. And you'll see here the DTG was doubled. Important to remember, patient had been diagnosed with TB, TB treatment had started, and so we need to remember to double the dolutegravir dose. And a few months later, the patient completed TB treatment. Finally, we get to reduce the pill burden. Patient had actually done incredibly well. Viral load was nicely suppressed. CD4 had taken a bit of a knock, and the creatinine had increased slightly, but was still fairly stable. And so what had happened, the ART was then refined. TB treatment was no longer an issue, so DTG could go back to once daily. And the patient then remained virologically suppressed thereafter and did incredibly well.
Patient number 7 was a 64-year-old male who presented to us with a really high viral load of 250,000, a very low CD4 of 50, and an HB of 9.3. So what we need to know from him is, when did you start ARVs? And he did. He started ARVs around about 2005. And all he could remember was that he was started on lopinavir and saquinavir. And I'm not sure if anyone would have been around in the 2005 era, But lopinavir and saquinavir, we would give it to patients if they were failing or if they were having ephedrine side effect. So he'd been on treatment for a really, really long time. And like I say, the regimen was quite complex. So when we saw him initially, what we needed to do was to start him on treatment. And since he was like already complex and he was on lopinavir and saquinavir, the assumption made that he'd already failed first line. So we'd switched him at the time to AZT3TC and atazanavir with Nova. That was in January of 2017. But because we'd switched him to AZT and 3TC, we brought him back a month later because he'd already started with an HB of 9.3 to see what the HB was doing. And then the HB had dropped to 7. And this is then we decided that we couldn't keep him on the AZT 3TC and we'd switched him to TDF FTC, but we left the atazanavir Nova in. And then we saw him a little bit after that because we were a little bit worried of the HB dropping. And also whenever one has low HBs, one also has to be a little aware of renal issues. So a month later, we saw him again and his creat had gone up to 152. So we couldn't then keep him on the TDF either and decided to switch him to abacavir 3TC and leave the atazanavir Nova in. Saw him again in June of 2017. And when we saw him again in June of 2017, the viral load was high in the sky at 270,000. The CD4 was 50 and the creat was still on the high side. So at that time, we re-adhered him again and then repeated his bloods again and found the viral load to be still very high despite all the adherence counseling and him being on atazanavir. We had no choice but to do a resistance test on him.
All right. And so this is a patient where it gets a little bit more tricky. Like I alluded to previously, your NRTIs here, you have to play around with the side effects. We've seen that the patient hasn't responded well to the AZT because of the anemia. We also know that the TDF is not really an option here because of the increased or the decreased renal function, the increased creatinine. So if we have a look at the resistance profile on the right-hand side here, we can see that the PIs, darunavir, has retained susceptibility, which is fantastic. You can see that the patient has various levels of resistance to both atazanavir and lopinavir. So darunavir is going to be our PI of choice. In terms of the NRTIs, we're sitting with a variety of resistance, but again, we have to think back to our side effects. AZT, despite being susceptible, is not an option here. Thankfully, we have some 3TC with potential low-level resistance, so we can throw that in. TDF, we know, is not an option. And abacavir has high-level resistance, but also if you look at the patient's age and the fact that he's a male, we have to remember that ABC also comes with risks of MI. So in this instance, we put the patient onto darunavir ritonavir as a BD dosing. Patient was also put onto 3TC, and then to supplement the regimen, dolutegravir, because there had been no INSTI history. And the patient suppressed very soon thereafter and has remained virologically suppressed since.
Patient number 8 is a 56-year-old male who presented to us again with a high viral load of 73,000, a CD4 of 39, which was really, really very low. So the history going is he started ARVs in 2007. He was diagnosed in 2007, but had not started ARVs yet. So we were seeing him 10 years later, and we now needed to initiate treatment on him. And we decided to go with tenofovir, FTC, and efavirenz. And in addition to that, we added multivite and cotrimoxazole as well. So Having started him on treatment, the follow-up subsequent to that is he came in a little bit late, and when we saw him in April of 2018, his viral load was undetectable from being very high, and the CD4 had moved up from 39 to 284. But however, a few months later, he was a shift worker. We did his bloods, and the viral load still remained undetectable. The CD4 was 231, the creat was 107, but in view of the fact that he was a shift worker, we couldn't keep him on efavirenz anymore. And so what we decided, with an undetectable viral load, we were going to keep the tenofovir FTC in and replace it with rilpivirine. And then what happened is we saw him subsequently in May of 2019. And in May of 2019, the viral load had gone up to 100. The CD4 had gone up very nicely to 360, but his creatinine sat at 111. So you can see the creatinine is starting to creep up. And in view of the high creat, we decided to do a hepatitis B surface antigen, and that was negative. And because of that, we had to switch him in view of the rising creat to a abacavir 3TC, and we left the rilpivirine in. That was in May. The subsequent bloods in December of 2019 shows his viral load was undetectable, the CD4 was 371, and the creatinine had dropped to 95. In September of 2020, the viral load had started to rise again to 2,200. The CD4 dropped slightly, and the creatinine was back up again to 112. Blood's done subsequently to that, because remember, every time you see patients and if their viral load is detectable, you re-adhere them and you say to them, you got to take your medicines properly, and we'll see you back in 3 months' time. But not all patients do come back in 3 months' time, and sometimes medical aids don't pay for a repeat viral load too soon. He arrived in March of 2021. At that time, the viral load had started to go up again. It was sitting at 7,500. The CD4 was starting to drop at 184, and the creatinine was sitting at 102. So in view of all of that, what we decided is that we should perhaps take him off the rilpivirine and put him onto atazanavir nova. And the problem we had at the time is that the medical aid didn't want to do the abacavir 3TC. They wanted him to switch to AZT 3TC, but the patient was most unhappy with the BD dosing. So he decided he will self-fund the abacavir 3TC so he could have it with the atazanavir nova and just take it once every morning. And then one just kept on badgering the medical aid to please allow the patient to have a resistance test or to fund for the abacavir. And then eventually they did agree to a resistance test, and this was the outcome.
All right, so this case has a few highlight points. The first is that it really does show the importance of adherence counseling. As you can see with the first-line regimen switching across to rilpivirine, the patient did suppress nicely, which had then gone up, and it took a few attempts before the patient, before it was switched. So important to remember adherence counseling, figuring out what's going on. Is it the drug that's failing, or are there issues with taking the treatment? The second thing is that, again, dosing schedule is really important for our patients. If you have the option to, and it depends where you work, whether it's public versus private. Public, you are a lot more restricted with what's available, but if you are in private and you have options and patients are able to self-fund, sometimes that is the way to go, and patients will suppress nicely on those once daily regimens. So if we have a look at his resistance test, we can see that the PIs have been spared, which is fantastic. That gives us options. NNRTIs have blown as we would expect. And if we look at the NRTI pairs, again, we have some issues with side effects, which we need to take into cognizance. So TDF is not an option here. Thankfully, we do have ABC and 3TC, which aren't to the high level resistance, but out of the panel is probably the best considering side effects and what is going to work for the patient. So patient was switched across to ABC 3TC, continued with the boosted atazanavir. And again, the medical aid still only approves the 3TC AZT, and the patient continued to fund. Patient did really well. So viral load nicely suppressed, CD4 starting to improve, and the creatinine nice and stable. And the patient remained virologically suppressed thereafter. So just an important one to remember, to advocate for your patients and give them options if you do have possibility for self-funding and options to other therapies.
The next patient is a 38-year-old female who presented to us quite pregnant. And at the time, the viral load was really high. It was 204,000 with the CD4 of 16. And in view of the pregnancy, she was quite far down. We had to kind of decide on what to do rather quickly. Apparently, she said that she was diagnosed with HIV a while back. And what we found is that when she was diagnosed with HIV, and this was in the private sector, she was pregnant and she was started on TDF, 3TC, and efavirenz, and complained of side effects of efavirenz to the doctor, who then just took her off the efavirenz and switched her to rilpivirine, and without even considering what the bloods were. So you can imagine that this patient who was on TDF, FTC, and efavirenz is now being switched to TDF, FTC, and rilpivirine. And do remember that if you have patients on rilpivirine and you're starting them on ARVs, the viral load has to be less than 100,000. Otherwise, the rilpivirine is not going to work. So this doctor did the switch to rilpivirine without having considered the viral load. And this is why when we are seeing the patient now, the viral load is really very high. And this patient is failing treatment because the initial treatment put out for the patient was just not working. So in view of the pregnancy, we decided we need to switch the treatment rather rapidly, and we needed to have done a resistance test urgently.
All right, so the ART at that time was switched to include TLD and atazanavir ritonavir. Taking into account the history, so patient has been on a first line, we assume she's failed, but secondly, the most important thing, there are two patients in this scenario, both the mother and the fetus. So it is very important to get these patients as suppressed as quickly as possible. And dolutegravir is very helpful in this case. We use it a lot in our third line regimens, even if it won't continue, but just to get rapid suppression so that you decrease the risk of mother to child transmission. And then if we have a look at the resistance test. So patient remained on that regimen throughout her pregnancy, and it was reassessed after. So patient was seen post-delivery in July of 2019. And in light of her resistance test, which we can see here, she retained susceptibility to the PIs, which we would expect since she'd been on efavirenz and rilpivirine. So we did have a lot of options. But the one thing we could do, considering the TDF and FTC along with the PI would likely work, since it is technically a second line regimen, we could drop the dolutegravir and refine that regimen a little bit for the patient. And the patient did incredibly well. She achieved and both maintained virologic suppression thereafter. And I think Dr. K would have to just correct me if I'm wrong on this one, but the infant was also HIV negative.
For certain. The next patient is a 53-year-old male whose initial presentation to us was a bit of a disaster. He had a CD4 of 4, a viral load of 820,000, a creat of 53. And in view of that, I said to you, whenever the CD4s are low, don't forget you need to do a cryptococcal antigen and you need to do a urine lamb. Both of these had come back negative. So the history he'd given us before that was that he was diagnosed with HIV and TB a year ago, and he was started on TDF, FTC, and efavirenz. He completed his TB treatment when he got to us. So when he got to us and we looked at these bloods, it just didn't make any sense because now he also didn't have the TB to complicate stuff. And in view of the previous drug history, we decided we'll keep the tenofovir and FTC in and switch him to a PI. And at that time in private, we had access to atazanavir nova. And if you remember with the EARNEST trial, it's not an issue to switch patients from TDF, FTC, efavirenz. And because of the EARNEST trial, we just recycle the TDF, FTC, and we add a PI in. And we know we get really good results. And in view of the low CD4, we added cotrimoxazole and some multivite. In May of 2019, when he followed up, his viral load still remained really high with the low CD4 cell count, despite him having reported good adherence. Re-adhered him again and said, no, you got to take your meds properly. And in July of 2019, the viral load was still really, really very high at 440,000. And re-adhered him again, left him onto the old meds. December of 2019, viral load was still very high, which is when we decided, no, we have to ask for a resistance test. Remember when we see patients and we have them on PIs, we always kind of think the PIs are working and the problem is always with the patient. So we re-adhere, and eventually we decided, no, you need a resistance test.
All right, so that brings us here to 20th of December, where a resistance test was done. So if you have a look here at his PI and his NRTIs, you can see that there is some drug resistance to the PI class as a whole. So again, we're going to tease out the darunavir, ritonavir A, he has had no exposure to, and B is also our choice for third-line regimens. So that would be our option and at a BD dosing. And then we have a look at our NRTIs. We're not sitting with a whole lot here. He's been on a few, he's been on TDF, FTC. So ideally, if we have the choice and we don't have any side effects to contend with and a good patient history, a strong, healthy patient, we look at the lowest rated Stanford scores. That is an indication of how much resistance or how susceptible the drug is going to be. So we want to pick the two with the lowest score if possible, and ideally in a fixed dose combination. So what we could choose here, we see that we have AZT, patient hasn't had exposure, we haven't had any issues with anemia previously, and AZT 3TC we know comes in a fixed dose combination. Because of the high levels of resistance, both in the PI class as well as the NRTI class, we want to add a third drug or a fourth drug just to beef up the regimen, and we have dolutegravir to do that. And patient did well. Patient virologically suppressed. March 2023, so 3 years later, patient came back and was still suppressed. And at this point, you can then start to refine the regimen if you feel that the patient is doing well and they have suppressed nicely. So in light of things like the Nadia trial, which we have seen, it shows us that dolutegravir with NRTIs that maybe don't have as much susceptibility as we would like has been shown to do well in second. While we can't extrapolate that to third-line regimens, as soon as we're putting it with darunavir, ritonavir, we can be sure that this regimen will be beefy enough that that patient will suppress. And the patient remained virologically suppressed thereafter, or sorry, I'm lying. This was in March 2023, so the patient still is due for follow-up.
The next patient is a 30-year-old male who presented to us again with a high viral load and a very low CD4. The viral load was 16630. The CD4 was 55. So the first thing you do when you see a patient like that, you want to know what treatment were you on before and when. So the patient said he was diagnosed in 2013 and he was started on TDF, 3TC and efavirenz. And when we saw him down the line, his viral load was really, really very high. And in view of that, we said, well, we need to move him onto second line. And because of the EARNEST trial, we recycled the TDF FTC and just replaced it with the PI. And the PI that was most convenient at the time was atazanavir with Nova. So this patient would just take 2 tablets once a day. This is what he was started on with us, or what we switched him to. And then the following follow-up in March of 2021, his viral load had reduced to 68. The CD4 had gone up to 132, and the creat was sitting at 64. You can see he'd done really very, very well. But the bloods after that, in October of 2021, the viral load had gone back up again to 494,000, and the CD4 had dropped again. And the patient at this point said, "Doctor, I'm taking my tablets," because you thought maybe he fell off the bus, but he didn't, and he reported good adherence. So we again re-adhered him, brought him back again, still reporting good adherence, but the viral load was still high. And now it is sitting at 312,000 and the CD4 at 47. And him having been on a PI, reporting good adherence leaves us with no choice but to ask for a resistance test.
All right, and so that's where we sit here. And I hope you can start to see the pattern, because we're starting hopefully to show you that we use a lot of the same drugs and it's not as daunting as it seems. So in this instance, patient had been on a first and second line regimen, had failed on a second line regimen. And you can see in his resistance test, so as we would expect, high levels of resistance to the NRTIs. PIs, thankfully, again, darunavir had retained susceptibility, and you had some level of resistance to atazanavir and lopinavir both. In terms of your NRTIs, you're not sitting with much. You're going to choose the best out of what you have. Patient has been on a failing regimen for a long time, and so you accumulate a lot of resistance, as you can see with the major resistance mutations available here. So if we look at the Stanford score, we can see that TDF, FTC, 3TC are sitting at the lowest, but still high level resistance. So what we do here, we take the 2 of the lowest, which is great. They come in a fixed dose combination. We have our darunavir, which can be dosed once daily. And to beef up the regimen again, because you have such high level resistance with your NRTIs, we again add in dolutegravir. And again, fixed dose combination, patient is taking 2 tablets once daily. And patient, again, suppressed really nicely and has remained virologically suppressed thereafter.
The next patient was a 39-year-old female who presented to us again with a high viral load of greater than 1 million with a CD4 of 29. According to her, the previous history is that she's been diagnosed and started treatment in 2013, and the treatment initiated was tenofovir, FTC, and efavirenz. But when we saw her with such a high viral load, and especially with such a low CD4, we'd asked for a resistance test, and with immediate effect, we needed to get her meds switched.
And so that's what we can see over here. So if we have a look and we think about her history, patient has failed on a first-line regimen. So if you have a look at the NNRTI resistance, like you would expect, we know efavirenz is really not a strong player, very low genetic barrier to resistance. So with failure on an efavirenz-based regimen, you're going to have some level of resistance and often high level resistance. So we discredit this class. Then we focus on the PIs and the NRTIs. So patient technically is going across to a second line regimen. So we can have a look here. PIs are susceptible. So we have a lot in our arsenal, which is great. Like Dr. K has mentioned, lopinavir, ritonavir, if you have options, not ideal, twice daily and GIT side effects. So if we have access to boosted atazanavir, that's perfect. Darunavir, we really want to leave for third-line regimens. So we have atazanavir, we can add that into the regimen. And then if we have a look at the NRTIs, we can see sitting here at the bottom, susceptibility, we still have AZT in our arsenal, so we can add that. And again, we know it comes in a fixed dose combination, so we can add along with 3TC. And like we know, the PIs are really, really robust, particularly with NRTIs if there is some level of resistance. So to have two susceptible drugs and one with high level resistance, the patient is likely to do well. So patient was switched across to a regimen containing 3TC, AZT, and boosted atazanavir. And then quite a while later, actually, the patient came in September of 2019 and complained of yellow eyes, which we know is cosmetic, but I think if any of us had to have yellow eyes, we would also want our drug switched. So again, thankfully, we had options. So if you refer back to your resistance test, patient at that point was virologically suppressed, the CD4 was doing well. And so what we could warrant here is a switch across to darunavir ritonavir, and then switching her NRTIs to TDF FTC. Patient remained virologically suppressed thereafter and has continued to do well on that regimen.
The next patient is a 52-year-old male who presented to us with a high viral load of 287,000, a CD4 that was very low, 28, and a creat of 61. So like I said, the most important thing is to know what the previous drug history was all about. So he was diagnosed in the public sector in 2005 and started on treatment. He was started on ACT, 3TC, and efavirenz, and then subsequently failed and was put onto second line where he was on TDF, FTC, lopinavir with ritonavir. So he presents to us on TDF, FTC, lopinavir, and ritonavir with a really high viral load and a really low CD4 count, saying that he is adherent to treatment. And in view of that, a resistance test had been ordered.
All right, so if you have a look on the right-hand side, just to emphasize some things that we've been going through, NNRTIs, patient has been exposed. We know that they don't fare well, especially with first-line regimens. And so there is a level of high-level resistance to efavirenz in particular. If we go up and look at what is going to hold our drug regimen, we look at the PIs, we can see that the patient, they've been exposed to lopinavir ritonavir, and there's high-level resistance to that, as well as to atazanavir. So really our option here, and as would be an option in third line, is you're going to go for the boosted darunavir. Darunavir would be dose BD here because of the level of resistance. And then we go down to our NRTIs. So a patient has been exposed to quite a variety of the NRTIs, and you can see varying levels of resistance to this. So again, we want to make the patient's life as easy as possible. We ideally would like to choose the drugs with the lowest level of resistance, but we also do have dolutegravir to, again, beef up that regimen. So even if your NRTI pairs are not the lowest and most susceptible drugs, we can beef that up with dolutegravir. So what was decided on here is obviously the boosted ritonavir at a BD dosing, dolutegravir thrown into the mix, and then along with that, TDF and FTC. And you can see that with the TDF in particular, there is low level resistance, not completely susceptible, but not a complete disaster, which is great. So patient then came back thereafter. The viral load had dropped nicely to 26. CD4 had gone to 250, but the creatinine had increased. And again, we're thinking about TDF. So we think about side effects. We now have a resistance panel. We can tailor the drugs to the side effects. In this instance, and if the Hep B is negative, again, we think about flares. We can think about dropping the TDF. And the patient in this instance was TDF was dropped and the rest of the regimen remained. So boosted darunavir, dolutegravir, and 3TC. Patient was followed up a year later in October of 2019, and you can see that the viral load had done well. CD4 had climbed slightly to 396, and the creatinine had settled at 66. So again, whilst we have options. We need to tailor these options to our patients and not be rigid in what we're following with algorithms.
Patient number 14 is very interesting. And the mum was seen in February of 2023. She was newly diagnosed with HIV, and at the time she was 24 weeks pregnant, and she was due to have her baby in May. Her bloods at the time was 48,400, which is really very high, considering the fact that she's already 24 weeks pregnant. The CD4 was 226 and the creat was 59. And in view of that, we decided to initiate her on ARVs, and the ARVs we know that will drop the viral load down very quickly would be TLD. So she was initiated on TLD as we laid our eyes on her on the same day. But in April of 2023, she had to undergo an emergency Caesar for preeclampsia. She did deliver a live infant, and at the time, the viral load was 44. However, when the baby was born, somehow the DNA PCR was not done at birth, but you can understand why, because this was like a totally prim baby, mum being eclamptic. So the PCR at birth was not done, and mum then arrived for her 6 weeks visit, which is when a PCR was done, and the PCR came back positive. And because the PCR came back positive, the next thing we needed to do absolutely urgently was run the bloods. Firstly, to confirm, because we couldn't believe it, because when mum delivered, the viral load was 44. And when we got the blood results back, the viral load was over 10 million, and the baby's CD4 percentage was sitting at 52. So in view of that, the baby weighed 3 kilograms. We needed to initiate ARVs immediately. So we put the baby onto ABC-3TC with lopinavir, ritonavir syrup, and cotrimoxazole. So at this point, remember, a resistance test was ordered. Every single baby who tests positive at birth needs, or at 6 weeks, needs to have a resistance test done if the mum's been on ARVs.
And so what's important here, and sorry, I actually forgot to add this in for Dr. K, but with this patient, the mom had been issued AZT, and it sounds like the baby hadn't got any of the AZT because the bottles had broken. So it's important to remember that the mother is a patient throughout that whole journey. We can't just stop in pregnancy when we see that the patient is nicely virologically suppressed. There is still the risk of transmission even after that period for a variety of reasons. And like Dr. K has emphasized, with kiddies who are HIV exposed and infected, it is crucial that we have an HIV drug resistance test on them. There is quite a high level of transmitted resistance from mother to baby. Thankfully, not in this case. The infant had had a resistance test 23rd of May 2023 and showed susceptibility to all ARVs. Important to highlight here, and not just for infants, but also for adults, is that we don't, if there is a need, you don't wait for the resistance test. In certain circumstances, patients need that viral load suppressed. So you start with what you think would be a good option, and you can always tailor later on. But in this instance, it was imperative that the baby was started on treatment as soon as possible.
Just a quick reminder on the previous patient, it is a catastrophe to get an HIV positive baby. And especially in private, where we discourage breastfeeding and medical aids provide mums with formula for 6 months. So to remember that AZT navirapine syrup is absolutely crucial. This was a lesson to me to make a point of really saying it over and over and over again to parents. But apparently this mum the bottles had broken, and I don't know how she didn't come back until 6 weeks. The next patient is a 57-year-old female who was ARV naive, but the special thing about her is she was diagnosed with HIV, was a shift worker, was in a discordant relationship. So when we did her bloods, her CD4 was 138 and the creat was 68. And so we needed to get her onto ARVs immediately. And the ARV choice we decided on was TDF, 3TC, and atazanova. And the dose of atazanova at the time was 400 because she was ARV naive. We didn't boost with any Nova. And she was started on these 3 tablets. So it was TDF, 3TC, 1 tablet, 2 atazanova 200s, and in view of the fact that she was a shift worker, we couldn't use efavirenz, so the next thing we had available was atazanova, and in view of the fact that she was still ARV naive, we doubled the atazanova dose and didn't do any Nova. And then she presents to us for follow-up subsequent to that, and her viral load was 1151, the CD4 was 217, the creat was 70, and she reported excellent adherence. She'd never, ever missed a dose. And we couldn't understand this because she was on TDF, FTC, and atazanova. So in view of that, we re-adhered her, repeated the viral load, which still continued to remain high despite the fact that she says she was adherent and adherent on a PI as well. So a resistance test was ordered.
All right, and so if you have a look over here at the resistance profile, you really do have quite a bit to play with. So your atazanova was used as your first-line regimen, but has retained susceptibility. And what you can see here is if we look at our NRTIs, in this instance, we are going to still retain the atazanova boosted with ritonavir because it is essentially now a second line case, and then optimize our NRTI backbone. So that leaves us with AZT, which we show full susceptibility to. And then again, like mentioned, we have 3TC AZT as a fixed dose formula. So this was chosen. So AZT 3TC plus atazanova, which has been boosted with ritonavir. And the patient was seen in February of the following year and showed really good viral suppression. CD4 was at 230, and the patient remained virologically suppressed thereafter on this regimen.
Dr. Bosch, I think we just need to mention what's interesting about the last case is that I think this was a primary transmitted resistance in her.
Yeah, agreed.
The following patient was a 61-year-old male who presented with a high viral load of 5944, a CD4 of 681. He was diagnosed with HIV a long time ago. He was on D4T, 3TC efavirenz, AZT, 3TC nevirapine, TDF, 3TC lopinavir with ritonavir. So you can see this is a very HIV experienced patient who, despite saying I'm adherent to treatment, is having a viral load sitting at 5944. And in view of this, we decided to order a resistance test on him.
All right, and you can see, like Dr. K has mentioned, he has quite an extensive ARV history, and that really does show up on his resistance panel. So you can see he's had exposure to the NNRTIs, so you see high level resistance here to both efavirenz and nevirapine, as well as quite extensive exposure to the NRTI backbone. And you can see high level resistance across the class. Thankfully, again, susceptibility is retained for the PIs, which is great. So there is the risk that the patient wasn't taking lopinavir, ritonavir, which we know again is very difficult, but thankfully it has retained its place in this class. So the option of choice here as the grounding force, ritonavir boosted atazanavir was chosen. And along with that, again, we look at our NRTIs and trying to optimize what we have. So TDF has the lowest Stanford score here, so lowest level of resistance. And second to that is FTC 3TC, which is fantastic. Again, we have TDF 3TC in a combination, so that was added. And for this case, this was a very, very long time ago. You could add in dolutegravir now, but in this instance, the patient had retained susceptibility to etravirine. So in this instance, etravirine was added, and the patient then achieved and maintained virologic suppression thereafter on that regimen.
The next patient was a 47-year-old female who presented with diarrhea and type 2 diabetes. At the time, her viral load was 5944, the CD4 was 681. And the first thing you need to do after you lay your eyes on the patient is get a previous drug history. So she was diagnosed in 2005. And at the time, she was started on D4T, 3TC, and efavirenz. And that was subsequently switched to AZT, 3TC, and nevirapine. Do you remember in the old days, we thought efavirenz was teratogenic, and we would switch patients off efavirenz to nevirapine. And she subsequently would have failed because whenever we see lopinavir with ritonavir in the mix, we can pretty well say that this patient was a second-line patient, and she was switched to TDF 3TC and lopinavir with ritonavir. And now when we are seeing her many, many years later, her viral load is sitting at 5944. So whenever we in private would see patients who would be on Aluvia, the first thing we would do was we would switch them to atazanavir. And what that meant, instead of patients taking 3 tablets in the morning and 2 in the night, when we took them to atazanavir, they would just take 2 tablets once a day. And this patient was then switched to TDF 3TC and atazanavir with Nova, and she was readhered. We saw her subsequent to that, and the viral load still remained high despite promise of good adherence. So we had no choice but to order a resistance test on her.
All right. And again, hopefully we can start to see the pattern coming through. Patient has had extensive drug history and has failed first line, second line, and now essentially needs to be put onto a third line regimen. So if we have a look at the NNRTIs, you have high level resistance as expected to both efavirenz and nevirapine, but retains susceptibility to etravirine, which in some patients does show some use in third line regimens. Looking at the backbone or the holding regimen, the PI susceptibility, we have susceptibility retained to darunavir, so that would be our drug of choice and can be dosed once daily in this instance. In this case, it was dosed BD. And then if we have a look at the NRTIs, again, we want to optimize based on susceptibility to drug. So we see here, TDF has retained its susceptibility, and we pair that alongside FTC 3TC. We know fixed dose combination. And in this instance, etravirine was added as well because of the susceptibility. So in January of 2014, the patient followed up again after switching to this regimen, and blood results at that time showed good virological suppression and a CD4 of 804.
The next patient is a 52-year-old female who presented with a history of diarrhea, but also admitted to defaulting treatment. She, at the time, said that she'd been diagnosed with HIV a long time ago. She was on TDF, FTC, and lopinavir. And already, if you're seeing patients who are on lopinavir, you know they're already on second line. So they have started their treatment a long time ago. And in 2010, this was subsequently switched to AZT 3TC, and lopinavir. So when we saw her and she complained of having defaulted her ARVs, and the thing to do then is to then reinitiate them back onto their old treatment. So we started her back onto her old treatment, which was AZT, 3TC, and lopinavir, and got adherence counseling to be done. When we saw her subsequently, the viral load had dropped, but it was still sitting at 581. So, like I said, in private, we'd had the option of taking our patients off lopinavir, which was a BD dose, big tablets, lots of side effects, and switching them to atazanavir nova, which then reduced the pill burden to just one tablet. So this patient continued to be on the AZT-3TC, but the lopinavir was replaced with atazanavir and nova. The blood results done subsequent to that, the viral load still niggly, sitting at 674, the CD4 at 620. We continued with the AZT-3TC, atazanavir nova, and just re-adhered her. Brought her back again. In July of 2016, the viral load was now 290, still niggly, with the CD4 of 398. Brought her back a year later, the viral load was still very niggly, re-adhered the patient, and brought her back again. The viral load is still very niggly, re-adhere, and eventually, by 2018, she was swearing excellent adherence, with the viral load still being 520. So now what one needs to remember is when you have patients who have niggly viral loads, the first thing is you got to readhere. And then despite all the readherence, we need a resistance test in private. And you can only get that resistance test in private if the medical aid would do the resistance test. And if the medical aid refuses to do the resistance test, you just got to push the adherence. And eventually the medical aid decided to approve a resistance test. And at that time, what we also decided is to take the patient off the AZT-3TC and switch her to a once daily dose according to the EARNEST trial. So her AZT-3TC was replaced with TDF-FTC, and we left the atazanavir nova in. When the bloods were repeated subsequently, despite the fact that this was now a once daily dose, the viral load still remained very high. And then we just absolutely insisted that we needed resistance tests, because this was just not fair on the patient who's now swearing adherence. The medication is made easier for her to take, and the viral load still remains high.
All right, so then we sit with this resistance test. And like Dr. K has emphasized, with patients with low-level viremia, important for adherence counseling. We know especially that on second-line regimens, whether they comprise PIs or dolutegravir, that in most cases, it is poor adherence that shows us those viral load blips. So adherence is really, really important. Developing relationships with your patients where possible to try and figure out how to assist. In this case, changing from a BD to a once daily dosing. Again, when you're in private, you do sometimes have these options. But if we have a look here at her resistance test, so the NNRTIs are not going to be an option for us here. We're on to third line regimen. They are not going to hold their own. Etravirine, yes, might still have a role, but if we're looking at things like efavirenz and nevirapine, we don't consider. So we go to the PI class. We can see that there is resistance to both lopinavir and to atazanavir, but we have susceptibility maintained with the darunavir boosted with ritonavir. So this we can use once daily here. And then we again look to optimize our NRTIs. So if we have a look here, we have varying levels of resistance of the NRTIs. TDF is our lowest, so that's great. We can use that. Again, FTC, 3TC, sitting with the back of a very close competition. We know that 3TC and FTC are much better for the patients, a lot better tolerated and good for viral suppression. Also comes in a fixed dose combination. So TDF, 3TC or FTC. In this case, etravarine has still some sort of susceptibility, so can be added into this regimen, which it was. And just to boost with the NRTI resistance, we've then added in dolutegravir here as well. So the patient on this regimen did incredibly well, achieved and maintained virological suppression thereafter. In this instance, you might consider dropping the etravarine for some patients because you do have a fully functional darunavir and no exposure to dolutegravir. So you have two really strong drugs in that regimen. So for ease of pill burden, you could pull back and remove the etravarine here. Okay, so I think that's all from us. Thank you so much. I know there were many cases, but I hope that there is some sort of pattern that has emerged. And I think we have, Claire, 5 minutes for some questions.
Hi, yes, thank you so much to both of you. You did amazingly well, and you've really illustrated the importance of HIV resistance, drug resistance testing with those cases. So thank you so much. Okay, something that caught my eye that I think is quite important. I work in public sector. Please repeat when resistance testing should be done in positive newborns.
Oh, okay, so this is a luxury in private, unfortunately. I think we know that the levels of drug resistance are really high. And I might be mistaken, but I don't think the updated guidelines include HIV drug resistance. You have to remember when we're looking at public sector, it is a programmatic sort of implication. And with dolutegravir now being introduced for infants, there is a huge push to put patients or infants that are over 3 kgs or over 4 weeks to push them onto dolutegravir-based regimens. A lot of mothers haven't been exposed to dolutegravir during pregnancy. So we expect that dolutegravir is going to cover if there is a level of resistance. So it is very different when we do HIV drug resistance testing in both adults and infants in private versus public. So unfortunately, not an option, but if you do have the option in private, it is a really good thing to sort of drive your treatment options. But from a programmatic point of view, there are very strong regimens now in place for infants, which is great. Dr. K, I don't know if there's anything that you want to add on that as well.
Not to this specific case, and I feel a bit bad for all the doctors listening in, but what I just want to say is just a few things. That if you're getting high viral loads, re-adhere your patients. Adherence is absolutely important. And then when you absolutely convince the patients taking their treatment, remember they need to be on that failing treatment to do the resistance test. Don't not let them be off the treatment, otherwise you wouldn't pick up the mutation. So they have to be on that failing treatment. So when they're on the failing treatment, so you've got to get them back onto their old treatment that they're failing. Make sure that the viral load is over 500. And generally what happens in private when we do resistance testing, the labs will run 2 tests. They'll run the viral load and they'll run the resistance testing. And if you're looking for dolutegravir resistance, you need to ask for the integrase resistance testing because it doesn't just happen automatically. So if you're absolutely convinced you need a resistance test, make sure the patient's adhering, is on the treatment, send 2 tubes to the lab, 1 for the viral load, 1 for the resistance test. If you need the integrase, do remember to add that on to say you're wanting an integrase test as well. Dr. Bosch?
Thank you. I think is there anything else that you'd like to add, Dr. Bosch? Oh, your microphone's off.
Sorry, I'm just having a look at some of the questions, but yeah, I think, so the one thing was about dolutegravir not being used in the infant instead of lopinavir or ritonavir. So I have, made a comment here just to say that would be an option now according to the new guidelines, but dolutegravir is a dispersible formulation. It might take a while for that to infiltrate across both public and private, but the guidelines are now in line with dolutegravir. And actually, Leon, thank you for that, has actually responded here as well. So in the new Department of Health guidelines, so infants whose moms are on a PI or on a TLD regimen get baseline resistance testing. So TLD is a second line. So essentially patients who are failing, where that would impact the infant's treatment, if that makes sense. So for patients who are on first line regimens, or on TLD as first line, there would be no role for HIV drug resistance. But then if patients are failing on second line regimens or TLD as second, there would be drug resistance. Thank you for that, Leon.
Excellent. Thank you so much. I am conscious of time, so I think I'll end it there. But I want to thank you two doctors so much for all the hard work you've done on this. We really do appreciate it. It has been very well received by our audience. And I'd like to thank Thermo Fisher as well for making this webinar possible tonight. So thank you all, and thank you so much to our audience for joining and for your questions. So I hope you all have a great week ahead. And thanks again. Thanks, Dr. Bosch and Dr. Mohammed. I hope you both have wonderful weeks.
Thank you, everybody.
Good night all.